As a member of the P-Scanner Stakeholder Research Prioritization Panel, you'll consider 9 research topics selected by an advisory board of patients, clinicians, and researchers. The information provided here serves as a general introduction to the state of the science on weight management obesity. You can view this entire presentation all at once, or you can jump right to the section that covers a particular research topic. Obesity is defined as excess body fat, but the amount or percentage of body fat in an individual isn't easy to measure in a doctor's office or clinic. Another way to identify if an individual is overweight or obese is to use body mass index, or BMI, which is calculated from an individual's height and weight. However, BMI isn't a perfect measure either. For example, someone with a great deal of muscle may weigh a lot, so they may have a high BMI but low body fat. But height and weight are easy to measure, so the BMI is commonly used. The National Centers for Disease Control and Prevention considers a BMI of 25 kilograms per square meter as overweight and a BMI of 30 kilograms per square meter and above as obese. As you click through slides 5 through 10, you can see on this map of the United States how rates of obesity have climbed. In 1985, only a few states had 10 to 15% of their populations who were obese. But every 5 years, we saw this grow and grow. Everyone recognized the problem, and so we set a national goal to reduce the rate of obesity back to 15% of the population as it had been in the 1980s. Well, guess what? Not one single state in the entire nation met that goal. Not one. Ethnic and racial groups have different rates of obesity also. The U.S. Black population has the highest rates of obesity, followed by U.S. Hispanic Latino people. In this country, whites and Asians have lower rates of obesity. Obesity rates also differ by age groups. Middle-aged adults from ages 40 through 59 have the highest rate of obesity compared to younger and older adults. Being obese increases the risk of other medical problems such as diabetes, heart disease, arthritis, stroke, depression, and other long-term problems. So, what actually causes obesity? There is no one single clear answer. Obesity may be affected by a number of factors, all of which may also interact with each other. These factors include genetic. For example, there may be a genetic predisposition to obesity in some individuals. Behavioral. Some people may simply eat too much or exercise too little, or too much stress or mental health issues prevent them from living a healthy life. Environmental. Perhaps the environment is not conducive to healthy living, or individuals are exposed to chemicals that impair their function. Physiological. Biochemical processes in a person's body might cause them to convert the food they eat more or less efficiently. Social and cultural. The social and cultural norms may put more or less emphasis on physical activity and food. All of these factors may interact to lead to obesity. Here's an example of how these factors might interact. Someone may have a genetic predisposition to having more body fat, but they may be able to overcome that susceptibility. If the balance of energy expended in physical activity is greater than the energy intake from food, then excess fat may not accumulate over time. Of course, the opposite is also true. So remember the rule. If you eat more than you burn off in activity, you may accumulate fat. There are numerous studies that show the relationship between exercise and consumption, and have led to a consensus guideline that says people should have 30 minutes of exercise 5 days a week. Do you? Here's another example of interaction. Epigenetics is the study of physiological and cellular traits that are the result of genes being expressed, that is, how they're turned on or off. They're not caused by genetic mutations, but chemical reactions could occur and might be triggered from exposure to environmental contaminants. Now at this point, you can continue to listen to the presentation on all 9 possible research topics, or when you're in Expert Lens, you can click the link next to each topic and jump right to the section that covers that research topic. For each topic, we provide key definitions and a brief overview of important points from current research to think about as you consider the topic. Topic 1. Compare different types of bariatric surgery, such as Roux-en-Y gastric bypass, sleeve gastrectomy, and adjustable gastric banding, to determine which ones result in the best long-term outcomes with the least risk. There are 3 types of stomach surgery that may be used to treat severely obese people. The first is gastric bypass. Roux-en-Y is the most common type of gastric bypass procedure. It involves creating a stomach pouch out of a small portion of the stomach and attaching it directly to the small intestine. Food bypasses a large part of the stomach and duodenum, the first portion of the small intestine. With this procedure, the stomach pouch is too small to hold large amounts of food, and by skipping the duodenum, the body does not absorb all the fat and calories from the food you eat. The second type is sleeve gastrectomy. A large portion of the stomach is surgically removed, leaving a stomach the size of a banana. It limits the amount of food you can eat by making you feel full after eating small amounts of food. The third type is adjustable gastric banding. A band is placed around the upper part of the stomach to create a small pouch to hold food. The band limits the amount of food you can eat by making you feel full after eating small amounts of food. The band can be adjusted to make food pass more slowly or quickly through the stomach. Appropriate candidates. Surgeries usually restricted to severely obese patients. These patients tend to value this treatment both for the potential to lose weight and to improve health that comes as a result of the weight loss. Access to surgery. Weight loss surgeries are very expensive and not available to all patients, depending on their insurance and if there are facilities to conduct the surgery. Lack of long-term results. Few studies show long-term results regarding weight loss beyond 2 years. One of the reasons is that it can be difficult to follow patients enrolled in the study for very long periods of time. Weighing the risks and benefits. Surgery comes with inherent risks, from lesser complications to much more serious complications, such as infection and even death. The possible complications need to be balanced with potential improvements that come from weight loss, such as reduction in risk of developing conditions like heart disease, diabetes, high blood pressure, and sleep apnea. Experience of symptoms. We need to better understand how patients experience symptoms related to these procedures, like nausea and vomiting, and how minor or severe these symptoms are. Primary care after surgery. Primary care physicians have little training and knowledge of how to care for post-surgical bariatric patients in the long term. Topic 2. Compare different web-based tools that support lifestyle changes and mental-emotional needs to determine which ones are most effective in maximizing weight loss and/or maintaining weight loss in people after bariatric surgery. Web-based tools are usually software applications that rely on internet connections, such as mobile applications you might use on a smartphone or tablet, or software on your computer. Some apps may provide health information, access to online support groups, and even tools to record weight, food, and physical activity. Lifestyle refers to regular activities individuals engage in that are under their own control. Eating and drinking, physical activity, smoking, and sleeping are some of these. Mental health or emotional needs may include how diagnosed conditions, such as depression, are managed, but might also refer to tracking individuals' moods or improve recall of actions. Web-based technology can help patients remember their actions, such as eating and exercising, or decisions they've made. Because web technology is often accessed by easy-to-carry cell phones or tablets, patients are able to record information as they go about their day, rather than trying to remember it all later on. Web-based tools may also improve or increase interaction with others who offer support to the patient. There's not much research that differentiates improved recall from improved support. Limited access. As in many areas of research, web-based technology studies primarily have involved users who are middle class, middle-aged, educated, and English-speaking. In addition, females tend to participate more in obesity studies than males, so we don't know if and how these supports might help other kinds of patients. Lack of long-term results. We don't have many studies that follow patients for long enough to know if the short-term outcomes of weight loss and health improvements are maintained in the long term. Topic 3. Understand whether and how antibiotic uses cause excess weight gain in early childhood or other ages. Antibiotics are designed to kill or change infectious agents such as bacteria in the body. But because they don't target just the agent causing a particular illness, the antibiotic may also kill or change the microbes in one's gut. This may then have a negative impact on the microbes that are associated with obesity and possibly other diseases, including asthma, allergies, and type 1 diabetes. Antibiotics and excess weight. The first report, which was in 1955, showed that antibiotic administration increased the weight of humans. Antibiotics in children. Antibiotics are the most frequently prescribed medication for children. Some, but not all, antibiotics may have long-term effects on children's growth and risk of obesity. Lack of long-term understanding. Most studies have looked at infants and children up to age 7 or 8. We don't know much about impacts on older children or adults. Topic 4. Compare different medications for obesity to determine which ones have the best long-term outcomes with the least risk. People use a variety of substances to reduce their weight. Some are over-the-counter or herbal supplements, while others are prescription medications. This topic focuses on prescription medications. Weight management medications work in 3 ways, but they don't all fall neatly into one category. Some may fall into more than one category. These 3 modes of action are suppress appetite, in other words, make you less hungry, impair dietary absorption, or reduce how much you absorb from the food you eat, and increase energy expenditure, or help you burn more calories. There are a number of medications that are used for weight loss in the United States. They act in one of the 3 ways described in the previous slide. Each has a different set of potential side effects and safety concerns. It can be difficult to make direct comparisons when the medications were not included in the same research study at the same time and with the same population of patients. This research topic would focus on direct comparison of the various medications. Topic 5. Compare different lifestyle changes such as nutrition, physical activity, mindfulness, and stress reduction, alone or in combinations, to determine which ones are most effective in maximizing or maintaining weight loss for individuals who are obese. Lifestyle refers to the activities that individuals engage in regularly that are perceived to be under their own control. This might include eating and drinking, exercising, smoking, and sleeping. Mindfulness refers to being in the moment and paying non-judgmental attention to experiences. Mindfulness may be practiced as meditation and would be considered one of the lifestyle changes. Call to action to improve lifestyles interventions. Studies of lifestyles interventions for obesity have resulted in meaningful changes in weight, such as 5 to 10% of weight lost. These interventions don't have substantial safety risks and can be conducted along with other types of treatments. The National Institutes of Health, NIH, which funds a great deal of health research in the U.S., has declared a call to action to improve lifestyle interventions for weight loss. Challenge of lifestyle interventions. Because these interventions require individuals to change behavior enough to result in weight loss, they can be long, for instance 6 months or longer, costly, and burdensome for participants. Lack of research standards. There are few standards for conducting or assessing nutrition and exercise interventions for obesity. This makes it difficult to directly compare the existing studies. Lack of research in mindfulness. There hasn't been much research in mindfulness meditation, but one review of 14 studies suggests it may decrease binge and emotional eating. Lack of long-term results. As with many types of research, we don't know if lifestyle interventions help people maintain their behavior change and/or their weight loss in the long term. Topic 6. Compare different lifestyle change support strategies, such as health coaching, individually tailored health messages, or communications with clinicians, alone or in combinations, to determine their effect in maximizing weight loss and/or maintaining weight loss for individuals who are obese. The focus on this topic is behavior change strategies that target actions that are affected by one's conscious decision-making. Health coaches support patients and help individuals set goals, overcome barriers that might prevent them from achieving their goals, and motivate them to make lifestyle changes. Health coaches can be nurses, medical assistants, or they can be other patients who've successfully managed their condition and are trained to help their peers. See topics 2 and 3. Individually tailored health messages are messages sent to patients regarding their health and are customized to the specific situation of each patient. They might involve content such as reminders, advice, or instructions. Communication with clinicians, that's physicians, nurses, pharmacists, and others, can happen in a variety of ways. Well, typically this involves one-on-one in-person conversation, but this also might occur during follow-up phone calls, by email, or other technology, or in group visits. Role of perceptions and self-efficacy in obesity. There are multiple articles and psychological theories of behavioral change that demonstrate that healthy behaviors are related to one's perceptions. For example, perceptions of one's ability to change a health behavior, also known as self-efficacy. Many studies demonstrate how interventions can improve perceptions and self-efficacy, and studies show how improved self-efficacy actually led to reduced rates of obesity. Intensity of weight loss programs. A number of studies have shown that patients in more intensive programs do lose weight. Lack of long-term outcomes. Few studies show long-term effectiveness of behavior change in programs. Some people tend to regain weight after participation in programs, and because the studies tend to follow patients for only a limited amount of time, long-term results aren't available. Behavior change programs are low risk. Behavior change programs generally have low health risks and can work with other treatments. Topic 7. Understand the barriers to and facilitators of selection, purchase or growing, preparation, and consumption of healthy foods. Now this topic focuses on factors external to the individual that impact their food-related behaviors, as compared to Topic 6, which focused on internal factors. External factors might include the natural environment, pollution, and availability of affordable grocery stores, nearby healthcare facilities, space for gardens, laws and regulations. Barriers refers to those external factors that might get in the way of someone's ability to be healthy. Facilitators refers to those external factors that might improve someone's ability to be. There are a number of possible barriers and facilitators. These are just a few. The U.S. Department of Agriculture defines a food desert as a low-income area where a substantial number or share of residents has low access to a supermarket or large grocery store. Others use this term more generally to indicate a local area that lacks affordable sources of fresh fruit, vegetables, and other healthful whole foods, which is also often a low-income area. These food deserts may have stores that mostly offer junk foods. A food desert puts up barriers to health because residents don't have access to stores where they can buy healthful foods. An example of a barrier is inadequate food labeling. Have you ever tried to read the label on the back of a food package and not understood a word you were reading? Right? Welcome to a food barrier. Lack of nutritional information on food packages and restaurant menus also prevents people from knowing what they're going to be eating, or from making good decisions about food purchases, even if they're motivated to eat healthfully. One facilitator of healthful eating might be to ensure that local regulations allow fruits and vegetables to be collected from neighborhood gardens and parks, or to encourage neighborhood chicken raising and other small farm animals. Why not? Another example is that some counties' parks and recreation departments have decided that they'll offer health options in their vending machines, like fresh fruit, bottled water, baked chips, versus traditional options such as candy bars, sugary soft drinks, fried snacks. However, with limited research on these policy and public health interventions, published results appropriately focus on the direct outcomes of the intervention rather than the impact on a population's level of obesity, and rarely do they integrate health data. Topic 8. Understand the barriers to and facilitators of adequate physical activity. Increased physical activity, some form of exercise, is one way to prevent and reduce obesity. Physical activity encompasses how active an individual is overall every day. This includes their general level of activity, such as standing or walking or other movement while going about their day. Examples are taking the stairs, walking or biking to do errands, moving while doing chores or work. Recent research has suggested that standing or walking can make us healthier. Another source of activity is time that's dedicated specifically to exercise, such as running, going to the gym, swimming, or playing sports. These are some examples of barriers and facilitators to physical activity. Local planning that focuses on access for cars rather than bike lanes. Or employers prioritizing large parking lots may motivate employees to drive to work rather than bike. That would be a barrier. People may be more active when they live in neighborhoods that have sidewalks to encourage walking in parks. Schools can also help residents of all ages be more active by sharing their facilities with the community outside of school hours. Employers can provide places for employees to park their bikes, store bike helmets, and even shower after exercise. These would be facilitators of physical activity. Similar to the topic of facilitators of healthful eating, the research in this area is limited and hasn't focused on the impacts on obesity. Topic 9. Compare the effectiveness of support by peer groups compared to support by healthcare teams on individual self-management capacity and their weight loss. Peers are those who are similar in experience, concerns, or challenges. When people find affiliation with others they feel are like them, they're more likely to feel a connection. The healthcare team involved with a patient may include clinicians, health workers, and community resources. Clinicians are those with licenses to provide healthcare services, such as nurses, doctors, pharmacists, nutritionists, social workers, or others. Health workers may be medical assistants, health educators, or community outreach staff. Healthcare teams refer to clinicians and health workers whether they're based in hospitals, physician offices, clinics, or other settings. Substantial research shows peer support is positive. Many studies look at peer support through online patient communities on social media, such as Facebook, or other discussion boards or websites sponsored by advocacy groups, one-to-one peer support, and group meetings. Support from peers helps with coping, emotional needs, and generating ideas for managing the activities of daily life when one has illness. You might meet a new BFF. Lack of research on whether peer support impacts health outcomes. There are few studies that look at whether peer support has an impact on health or medical outcomes. Patient-contributed data is becoming more important in research. There are a number of online patient communities that have started to use the information provided by patients to drive research ideas and to proactively collect data from patients to answer those research questions. Few studies compare peer support directly with healthcare team support. Thank you for joining us on this adventure to improve the efficiency and relevance of research that we hope will lead to better health for all patients.